venetoclax-based lower intensity regimens are the current standard of care for older or unfit patients with AML. However, certain high-risk groups still do not have favorable outcomes. We know that certain AML harboring mutations in TP53, FLT3, and RAS are known to be associated with primary and acquired resistance to venetoclax. However, long-term outcomes with HMA venetoclax regimens in specific genomic subgroups is not very well described. So we had initiated a clinical trial of decitabine with venetoclax in newly diagnosed and relapsed refractory AML. And in this ASH abstract, we present long-term data in specific mutational subgroups. So this was a single center phase 2 trial combining 10-day regimen of decitabine with venetoclax. We enrolled newly diagnosed patients with AML who were older than 60 years, secondary AML regardless of prior therapy, as well as relapsed refractory AML. Patients were ineligible if they had a prior BCL2 inhibitor or had a favorable risk cytogenetics, so including APL and core binding factor leukemia. In terms of the treatment administered, patients received decitabine 20 milligram per meter square for 10 days for induction, followed by 5 days for consolidation. Venetoclax could be held on cycle 1, day 21 if the bone marrow showed blast clearance, and we also allowed further reduction in venetoclax duration during consolidation in order to minimize myelosuppression. And we also allowed targeted therapies in patients with certain mutations. So we have enrolled over 199 patients till date, and 55% of the patients were older than 70 years. 63% patients had ELN adverse risk disease. And for this report, the median follow-up duration was 24.7 months. So among the more interesting findings were outcomes with the FLT3 inhibitor, venetoclax, and decitabine triplet. Among newly diagnosed FLT3 mutant AML, the CR/CRi rate was 87%, with negative MRD by flow cytometry in 82% patients. The median overall survival was 24.5 months, and median duration of response was 20 months. These outcomes compare favorably in the frontline setting with azacitidine venetoclax doublet from the VIALE-A trial, where FLT3 ITD mutant patients had a composite CR rate of 61% and median OS of 11.5 months. Among relapsed refractory patients with FLT3 mutations, half of the patients were exposed to a prior FLT3 TKI, and the overall response rate in this population was 61%, with negative MRD by flow in 70% patients. The median overall survival and duration of response was 6.6 months. We will see at this ASH, other investigators will present other triplet combinations with FLT3 inhibitors for AML, and cooperative groups in the US are also planning such triplet regimens. So it'd be very interesting to see multi-center results of such approach. Among other frequently encountered mutational subgroups, we found that patients with NPM1 and IDH mutant AML had favorable outcomes as expected. In the frontline setting, the CR/CRi rates were 80 to 88%, high MRD negativity rate of 90%, and median OS extending beyond 30 months. Another interesting finding was that in patients with ELN adverse risk mutations of RUNX1 and ASXL1, such patients were previously recognized to have poor outcomes with chemotherapy. And we noted a trend towards improved outcomes in these patients, which was not previously recognized. The CR/CRi rates were modest, around 56 to 83%. However, the median OS in RUNX1 and ASXL1 mutant patients was 15 to 16 months. My colleague, Dr. Short from our institution, and other investigators have reported similar findings in RUNX1 mutant AML, and there has been recent preclinical data showing that ASXL1 mutant AML may be particularly sensitive to HMA venetoclax regimens. In addition, patients with TP53 and KR NRAS mutations had suboptimal outcomes. The CR/CRi rates were high at 70%, but the median overall survival for TP53 mutant AML was 5.4 months, and for RAS mutant AML was 12.1 months. Outcomes were modest as expected in the salvage setting, but these trends in the specific mutational subgroups we discussed were more or less preserved. Yeah, so one important implication is that, with the evolving therapeutic landscape, we're seeing a change in the prognostic impact of of some of the adverse risk biology. So outcomes with the triplet combination with FLT3 venetoclax, and hypomethylating agents are looking quite encouraging, particularly for these older unfit patients who are often not candidates for stem cell transplant. And lastly, while outcomes in TP53 mutant AML haven't changed with the introduction of venetoclax, we are seeing promising trends in the adverse risk groups of RUNX1 and ASXL1 mutant AML. And this is certainly encouraging for our patients with these mutations.